and welcome to Voices of Wisdom, Thyroid's podcast designed to share thyroid cancer pearls of wisdom from clinicians for clinicians. Think of it as a fireside chat where over the next 15 to 20 minutes, we will be talking to international experts who will share their wisdom, offering practical advice to clinicians in a variety of common and sometimes complex clinical scenarios. I am your host, Dr. Janice Pasieka. I'm a surgical endocrinologist in Calgary, Alberta, Canada. I'm excited to host Thyroid Voices of Wisdom podcast, in addition to the other educational materials on thyroid cancer management that Tyros has been providing through our website and weekly webinars. We hope these podcasts will complement our other activities by providing short, easy-to-digest sound bites of clinical issues that we all face in the treatment of thyroid cancer patients. In each episode, I will be joined by a distinguished international guest who brings their unique perspective and expertise to the discussion. Today, we are going to take a deeper dive into molecular diagnostics for thyroid nodules. I am thrilled to welcome Dr. Erik Alexander, a leading endocrinologist from Brigham and Women's Hospital in Boston. So whether you're a surgeon, endocrinologist, pathologist, medical oncologist, or a nuclear medicine specialist, these podcasts promise to be a pivotal resource in your quest for knowledge in the care of thyroid cancer patients. So let's get started. Let me bring to the microphone Dr. Alexander. Welcome, Erik.
Thank you, Janice. Great to be here.
Erik, the world of thyroid cancer continues to evolve, and currently the molecular signature of thyroid nodules has been utilized by many to help with the preoperative diagnosis of intermediate thyroid nodules, provide guidance in therapy and prognostication of select thyroid cancers. However, the landscape can be very daunting for most of us clinicians. It is constantly changing. Erik, can you provide us with an overview of the type of molecular testing currently available?
Of course. And I think the way that you framed it, Janice, is really the important starting point, that as we think about molecular testing and its application to the clinical world, it's important to think that we can use it from a diagnostic standpoint. We can also use it from a prognostic standpoint, and then we can use it in particular for targeted therapy and individualized care. And those are really three different buckets. But at the present time, the greatest advancement, the most active area where molecular knowledge has moved into the clinical realm has been the diagnostic testing platforms. And most notably, primarily in the United States, the use of two well-validated and used tests, one referred to as Afirma, the gene sequencing classifier, and the second referred to as ThyroSeq version 3, which are both the most latest of the platforms that continue to evolve and iterate.
Great. So for this podcast, we'll go in those three categories you just outlined: the diagnostic, the prognostication, and maybe helping with the role it plays in advanced thyroid cancer. So let's start with the workup of a thyroid nodule. Clinically, when faced with an intermediate Bethesda 3 or Bethesda 4 nodule, do you recommend molecular testing in all intermediate nodules? And if so, how do you decide which of these tests to use?
No, it's an important starting point. And I think it's always important for us as clinicians to pull ourselves back from the all or none use of something, even when it's perfectly an important step forward in terms of care. And where I'm going with that is certainly, I think as clinicians, it's important we don't lose sight that we have demographic assessment that provides risk understanding. We have sonographic and other imaging findings that will help us with risk assessment. We have clinical symptoms at times that come forth. But importantly, molecular understanding is now adding yet another layer that I view as synergistic and not simply additive to that process. So commonly, it is the Bethesda 3 and Bethesda 4 thyroid nodule where this diagnostic use of these molecular tests has found its greatest benefit, because there was quite a bit of unnecessary surgery because the Bethesda 3 and 4 categories still continue to show some risk of malignancy, but it's low. It just can't be conclusively determined as benign. And so these tests have really been developed to try and maximize their negative predictive value. And I think that's a durable finding in both of these two leading tests.
And which one? Are they equal, or do you prefer one over the other, or is it what you can get your hands on?
A little bit of both. I'll give you my certainly use in my clinic. I think that when you look at the first step for what makes a good molecular diagnostic test related to the thyroid world, we all pushed for many years to ensure that there was very high quality clinical validation performed on this test. And what that really means to me is the equivalent of a phase 3 type study, a blinded or multi-center prospective study that gives us really the clear data. And there are many tests out there that are not quite at that point, but I would argue both the Afirma GSC and the ThyroSeq version 3 do have those very strong validations. The second piece of data, though, I look at is how it really plays out in the real world, because we all live in diverse practice areas, and there are often nuances as to what types of patients and nodules we see and what a Bethesda 3 and 4 situation really means. And so so-called clinical utility data, which is really the practice data that comes forth now that the test is widely used. To me, when I look at those data, I find that I have a little bit more support in using the Afirma product because it plays out very similar in those publications to the original validation. The concern when you deal with DNA-based mutation analyses really surrounds, in my opinion, the interpretation of what it means to be positive for a mutation in the gene called RAS. BRAF, which is the other big category of mutations when positive, is fully diagnostic of papillary thyroid carcinoma. But the real concern is when you have a mutation in the RAS gene, we see that that can exist in many patients in a benign process as much as it can in a low-risk cancerous process. And that is what has at times created some uncertainty about the clinical utility data that come forth.
So if you do this test on an intermediate nodule and it comes back with no mutation, is that good enough to say, this is benign, I don't need to see you again, don't worry about this? If all of the other clinical things, as you said, the history, the physical exam, the ultrasound line up that this is benign, is that good enough?
I think so for both tests. Remember that for the DNA-based products, we are talking about, if you will, the lack of a mutation or a fusion or the lack of identified gene change. That's the ThyroSeq platform and its basis. When you talk about Afirma as a gene sequencing classifier, it's an RNA-based assay. And so there's no discrete single gene it's looking at. It's looking at the pattern of about 1,000 different expressed units. But both of them have been well validated, and the clinical experience would support that a negative test for either of them is a confidently negative test, similar to a benign FNA cytology or Bethesda 2 reading.
So what happens when you find a mutation? Let's look at from the ThyroSeq. You find an actual mutation. What do you do next there? Does that mean they have cancer and it needs to come out, or what's the process?
Yeah, I think that's the complexity right there. And probably the reason that I'm a little bit leaning against that product, because I don't always know what to do. I think if you do receive a mutation in the BRAF gene, you'll feel confident that that is a cancerous nodule with all likelihood, and that indeed it should come out. And then you have a discussion about whether that helps you prognosticate what type of surgery to consider. But for some mutations, we don't really understand their overall risk of watching them without intervention, or whether they immediately need to be removed, which always carries some small risk, even in the best of hands.
Yeah, you alluded to the RAS mutation. I always found that one the hardest one because it was a mutation, and yet some of these, it's a mutation of a benign follicular adenoma. Can you take us through the different RAS mutations and which ones we should be a little more concerned with and which ones not?
There are different isoforms of RAS, and I'm not sure the data yet are completely strong enough to know if HK or NRAS necessarily carries risk assessment that is meaningfully different, though. There certainly could be new data coming on that. What I always kind of anchor on as well is I do think the data are quite strong if you are aware that there is a mutation in the gene RAS, but then a secondary mutation in certain other oncogenes. I do think we realize that is a higher risk malignancy quite confidently.
And that sort of brings me to the next kind of question. Are there certain mutational patterns or molecular signatures that we as surgeons should be aware of that maybe indicate upfront a more aggressive operation the first time? In other words, the ones that you're more likely going to recommend radioactive iodine.
I think there definitely are discrete mutations. This, again, would be in the DNA side of understanding molecular alterations. There are distinct mutations that do appear to be, again, quite confidently cancerous. For example, the BRAF mutation findings in a nodule, the positive TERT promoter mutations, NTRK fusions, again, RAS mutations with a secondary mutation identified. I would be very concerned with all of those as, if you will, higher risk. Now, that plays in then to important prognostic thinking that will then weigh both into the whole team's approach to this. And I do think it's a team-based decision together with the patient, really, as to what we do. There is not a discrete study that has told us one mutation should equate to one type of surgery or radioiodine, yes or no. It really still is an integrated thought process. But by all means, the higher the risk that we begin to think, the more then we should think about a near total thyroidectomy as opposed to a hemithyroidectomy.
Now, we've covered active surveillance in a previous podcast, but I'm curious of what your opinion is if the molecular signature of a small, less than 1.5 centimeter papillary thyroid cancer that you were likely going to offer active surveillance on. Do you get molecular testing on that? Does it influence what you would then do?
So it really does not, and I actively don't. There's certainly a cost we should remember to all of these tests, and many times a cost that's not supported by insurance or other kind of standard of care approaches. So that can be limiting in and of itself. But most importantly, we do not have the data yet that supports upfront determination of a molecular signature is a strong enough predictor of downstream risk that it forces an exact treatment pattern, especially with small nodules. And even when the BRAF positive finding was looked at in papillary carcinoma as a risk factor, the data would suggest that it fell out as an important risk factor in a univariate analysis, but not necessarily in a multivariate analysis when one understood already the histology and other findings where that risk was also conveyed simply based on stage and lymph nodes and findings like that.
So the clinical aspect of the nodule still sort of trumps this molecular signature then?
I think so. It's that integrated fashion. It's not just the clinical, but also at times if we have cytology or histology, what is that telling us? What about the ultrasound? Do we see lymph nodes, et cetera? Things like that.
So molecular testing, you may have already answered this, is not utilized in every healthcare system worldwide. And the question is, should it be? Is it something that other systems should be looking towards adapting in their healthcare system?
I think it should with time. And as all things in medicine evolve, it takes time. And each healthcare system has many different forces at play that allow the progression of the next step to move forward. But, I think what we have shown in the last decade, which has been a rapid evolution in this space, is that as we begin to understand the pros and the cons, we do understand that there is a space here for the value added proposition of molecular understanding of thyroid nodular disease and at times thyroid cancer.
So it appears that molecular testing is very helpful in triaging patients, particularly with the intermediate nodules. But what about after surgery? So operate on a patient that has cancer. Do I need to get molecular testing on that nodule? Does that help you or the healthcare team in any way?
At the present time, I still do not actively then assess the genetics of all of my thyroid cancers after they've been resected. And it really comes down to what was actively discussed in the 2016 American Thyroid Association guidelines, which is that idea that some molecular analyses like BRAF positivity could be looked at as an important risk factor when it's a singular variable. But as you start to put together all the pieces, in particular, you receive the histopathology and the understanding of the tumor assets and the nodular lymph node metastases or not, the broader picture of the TN and M staging, then you realize that the molecular signature doesn't necessarily add additive data. And that's always been the concern. So it's not to say that it will not prove to be value added into the future. It just means we need to understand what subsets and where it perhaps provides the best usage to understand the prognostic implications ahead.
Well, what about in recurrent disease or, these really advanced thyroid cancers? Does it help you there?
I think it does. And I think that's kind of the evolution of my last response, which is as we're starting to find some of these subgroups, we do start to understand where we get prognostic information from the molecular signatures. And this, of course, now will be generally DNA-based molecular signatures. Separately, there is an RNA-based prognosticator that is starting to be investigated. It goes by the name GRID and is not yet for commercial use, but with time, hopefully the data will suggest it could be useful. When I get into, though, more advanced disease, and I am starting to think about whether I need to involve my medical oncology colleagues or start to think about targeted therapy or just overall risk assessment, understanding multiple mutations, then I do think a broad understanding of the genomic drivers of the tumor can be very useful. And if it can be supported by the healthcare system to obtain it, I do think it's useful.
So to summarize, Dr. Alexander, fill in the blanks here. Molecular testing in the workup of thyroid nodules should be considered when?
When there's a clinically relevant thyroid nodule that does have Bethesda 3 or Bethesda 4 indeterminate cytology. And I think the important last aspect to this is when we believe that the data obtained through molecular testing would impact or change our clinical care.
The following mutations or molecular signatures that are consistent with cancer and may influence the extent of surgical intervention are?
Well, BRAF positivity, RET, PTC fusions are very prognostic of cancer. NTRK fusions are very prognostic and positive. And then I would also say we keep our eye here on the RAS positive ones with all of what we've just went through, at times acknowledging if it's singularly a RAS mutation, maybe that influences us on a more limited surgery. If there's multiple mutations in addition to RAS, maybe that pushes us a little to more extensive surgery.
And then finally, the benefit of molecular testing in advanced disease is?
Well, it really is all about individualized therapy, that if we can target the right molecule that might be available to the right driver mutation to inhibit that uncontrolled growth, then we have a very good chance of having a better positive outcome of that intervention. And for patients with advanced disease, that's really meaningful.
Erik, that was fantastic and a very informative discussion. But before we wrap things up, I thought we should end each podcast with a little extra knowledge for our listeners, something beyond medicine, and take advantage of our international reach. You live in a wonderful cosmopolitan city. Can you tell our listeners a hidden gem of Boston that they should definitely visit when in your city? Something that we won't find on the top 10 TripAdvisor search.
I would love to. I was introduced actually to this by my son, who's a political scientist. So with that in mind, understanding that Massachusetts also has a great history in government and the start of the United States, of course, he introduced me to the Massachusetts State Archives, which may or may not sound like a place to visit, but indeed they actually have a few very interesting pieces on display in a small museum that is very easy to access, very near the John F. Kennedy Presidential Library, so you can do both at the same time. But you can see an original old copy of the Declaration of Independence. You can see many of John Adams' original works. You can see some of the historical core printed documents of democracy. And who knew that they were living so close to where I live? So that was a real fun one to visit.
Oh, fantastic. Thank you for that. That brings us to the end of our podcast, Voices of Wisdom, on molecular testing in thyroid disease. I want to extend a special thank you to our distinguished guest, Dr. Erik Alexander, for his invaluable pearls of wisdom. If you have any questions or suggestions for future podcasts, email us at voicesofwisdompodcast@gmail.com. To date, we have produced ones in active surveillance, the rising thyroglobulin level, and unexpected findings at surgery. So be sure to check them out. And if you liked our podcast, please subscribe to our webinars, which air live every Friday morning at 8 a.m. Eastern Time. This is a series for thyroid clinicians and researchers that cover breakthroughs in thyroid cancer research and treatment in the form of journal clubs, state-of-the-art lectures, multidisciplinary tumor boards, and a lively panel discussion. Just visit thyro.expert/subscribe or click on the link in the description. I want to thank you all for joining us today, and I want to leave you now with another quote from one of my heroes, Sir William Osler, who said, "The philosophies of one age have become the absurdities of the next, and the foolishness of yesterday has become the wisdom of tomorrow." Reflect on that today when you're in the clinic. And with that, I want to wish you all a pleasant day.